Why first? Historically, most early trials for the hypertension used the diuretics. See, most of the times, diuretics are the very, very important drugs to be prescribed in all the hypertensive individuals, especially elderly hypertensives who use only the diuretics, even the low dose of the diuretics, like hydrochlorothiazide 6.25, 12.5, chlorthalidone 6.25, 12.5, or your furosemide, maybe 20 mg or the 40 mg, or the spironolactone 25 mg or 50 mg. Even with the small doses of the diuretics, we can control majority of the hypertensive individuals. And in fact, these are the supposed to be the most useful drugs in the management of the hypertension for the simple reason that they reduces the fluid value, they reduces the blood value, they reduces the preload. So that how it helps you in the management of the hypertension, in reducing your preload, in reducing your left ventricular hypertrophy, etc. So they inhibit the renal reabsorption of the sodium. You all know that glucose and the sodium, they are filtered in the glomerulus and again they reabsorbed from the proximal convoluted tubule. So to prevent this reabsorption of the glucose, we use the SGLT inhibitors like your dapagliflozin or empagliflozin. In the same way, to prevent the reabsorption of the sodium, so we use these diuretics. So therefore, along with the sodium, there will be also the water loss is also associated along with the sodium loss, natriuresis, and then the diuresis. So this is the initial modest loss of the extracellular fluid value. On long term, this fall in the ECF volume leads to the resetting of the circulation with the restoration of the volume, but lower the SVR. What is SVR? Systemic vascular resistance. So that is the reason for your peripheral vascular resistance. So once it reduces the peripheral vascular resistance, it also acts like a vasodilator, like your calcium channel blockers. You have the three types of the diuretics: thiazide or thiazide-like diuretics, or loop diuretics, and potassium-sparing diuretics. Thiazide diuretics: chlorothiazide, hydrochlorothiazide, chlorthalidone. Thiazide-like diuretics: indapamide. Loop diuretics, you have the furosemide, torsemide, etc. And potassium-sparing diuretics like spironolactone. So this is the different sites of the actions of your diuretics. The glomerulus, PCT is the proximal convoluted tubule, loop of the Henle, distal convoluted tubule, and C where the F stands for the furosemide, H stands for hydrochlorothiazide or chlorthalidone, I stands for indapamide, M is the metolazone, and S is the spironolactone, and A is the amiloride or triamterene. So these are the different diuretics acts at the different places, and mostly it acts at the distal part of your loop of the Henle or a distal convoluted tubules. So diuretics are very easy to use, but most of the times if you use in higher dosages, and definitely you can invite a lot of the side effects, especially electrolyte imbalances, sometimes metabolic side effects, sometimes hyperuricemia, etc. So hypokalemia, hyponatremia, so these are very common, hypovolemia, and leads to the metabolic alkalosis. Impotence is not that common with the diuretics, but very common with your beta blockers. But sometimes with the large doses of your diuretics and a prolonged duration, therapy may cause impotence. It is not lipid-friendly diuretics because they reduce the HDL, which is a very, very, very protective atherosclerotic lipoprotein. It raises the triglycerides at the high dosages. Ineffective in the renal failure. So thiazide diuretics are contraindicated once the GFR is less than 30. So as long as the GFR is good, more than the 60 or more than the 45 or more than the 30, so usually we use the diuretics like thiazide diuretics. But once the GFR is less than 30, you have to stop using these thiazide diuretics and start using loop diuretics like furosemide or the torsemide. Special indication is the elderly. So as I told you that in the elderly, so which type of the hypertension you get it? Is it ISH or IDH? Isolated systolic hypertension or isolated diastolic hypertension in elderly individuals? Janardhan, which hypertension you see in elderly individuals? Isolated systolic or isolated diastolic? Isolated systolic. So systolic blood pressure will be more than 140 and the diastolic blood pressure will be the normal, less than the 80. But most of the elderly individuals, the blood pressure will be 180 by 80, 170 by 70. Okay, so in such individuals, your definition is ISH. Only two drugs are useful. One is the diuretic, the second one is the calcium channel blockers. So in the diuretics, we use the hydrochlorothiazide or chlorothalidone in some individuals, but those people who can afford the best diuretic in such individuals is indapamide, because indapamide is metabolically friendly diuretic. It won't disturb your lipid profile. Indapamide won't cause hyperglycemia unlike other diuretics. So all the diuretics, they may cause hyperglycemia and hyperlipidemia. All the diuretics are contraindicated in gout. So the gout, you don't use the diuretics. And diuretics are also contraindicated in pregnancy-induced hypertension. In pregnancy also, hypertension, we should not use the diuretics. And what is the other class of drugs contraindicated in pregnancy? Good. Yes, and ARBs, because fetal anuria. So they may cause fetal anuria. So that is the reason diuretics and ACE or ARBs are contraindicated in the pregnancy. So specific agents, hydrochlorothiazide, we use 12.5 and 25 mg. Indapamide, 1.25 mg to 2.5 mg daily. May include potassium sparing diuretics to reduce the tendency to hypokalemia. So that is the reason hydrochlorothiazide is combined with the amiloride or triamterene. Because when you combine these potassium sparing diuretics, so the chances of hypokalemia is very less. Loop diuretics are very, very useful drugs, especially in the setting of fluid overload. So the people with orthopnea, the people with PND, when your diagnosis is heart failure. So once the GFR is very less, maybe less than the 30 with the pedal edema, puffiness of the face. So obviously the diuretic of choice is the loop diuretics. It's a very potent drug. You all know that. Lasix, your furosemide or now the torsemide. These two are very potent loop diuretics. Used in patients with the creatinine clearance less than the 30. Examples, furosemide, torsemide, bumetanide, and ethacrynic acid. So out of them, furosemide and the torsemide are very, very useful drugs. See, there are different side effects of the loop diuretics because they are very potent drugs. So once they cause diuresis, so obviously dehydration, hypokalemia, hyponatremia. As I told you, they increases the blood sugar, hyperuricemia. So that is the reason they are contraindicated in gout, metabolic alkalosis, circulatory collapse. So that is the reason when you are using the loop diuretics, we always see the pulse and also we see the blood pressure. Okay, when the pulse is low volume, so obviously the patient is in hypotension. Low volume and tachycardia, most probably the hypotension. And check the blood pressure. And when the systolic is less than the 90 or the less than the 100, so definitely we don't use the loop diuretics, even though the person is in edematous condition. Rash and ototoxicity. So sometimes ototoxicity can be caused by your furosemide. So what is the other drugs which can cause the ototoxicity? Any antibiotic? Good, aminoglycosides like your gentamicin or amikacin. Okay, so they may also cause ototoxicity. Precautions and special consideration of the loop diuretics, they are very effective in the renal failure. In the CKD, in the setting of the CKD, these loop diuretics are the drugs of the choice once the GFR is less than the 30. So that means the people on dialysis. So the people who needs transplantation. So when the GFR is less than the 15, so you consider them as the ESRD. There we use only the loop diuretics. Higher doses of the loop diuretics may be needed in the heart failure and the edematous or renally impaired patients like CKD. A word about the potassium sparing diuretics. They are the weak diuretics alone, but any two antihypertensive effects with the loop or the thiazide diuretics. So usually we don't use the spironolactone alone except in the settings of your cirrhosis of the liver or portal hypertension. In all conditions where we use the spironolactone, we use it in a combination of the drugs. So along with the diuretics, along with the loop diuretics, and use in combination with other diuretics to avoid or the reverse the hyperkalemia. Avoid use in patients with the creatinine more than the 2.5 milligrams. In which class of the antihypertensive medications you should be very careful in using these potassium sparing diuretics? Out of your ABCD, AS and ARBs is a good answer. So when you should be very careful in using the potassium sparing diuretics when the fellow is already on the AS or ARBs, because AS and ARBs may cause hyperkalemia. Okay, so there is a very common side effect. So that is the reason when you are using the AS or ARBs, when you want to use the spironolactone, always check the potassium levels. When it is less than the 5, so then only you have to start this using. Once the potassium is more than the 5 or 5.56, and definitely contraindicated to use these drugs. So the common examples here are the spironolactone, amiloride, and triamterene. So what are the common side effects of the spironolactone other than your electrolyte imbalances? Good, gynecomastia is very common with the spironolactone. So that is the reason now we have the potassium sparing mineralocorticoid receptor antagonist like finerenone. Beta blockers are very, very useful drugs. And in fact, if you see the rural India, very common, attend 25 mg, 50 mg, 100 mg, or etenolol plus amlodipine. Okay, so these two are the very common drugs pan India. They are the second commonest class used in the initial trials. Beta blockers are very useful in reducing the heart rate, in reducing the myocardial contractility, and also it reduces the renin release. So RAS system activity is very, very important in the pathogenesis of the hypertension. So once you are using the beta blockers, you are reducing the heart rate, you are reducing the myocardial contractility, and also the renin release. True mechanism of the antihypertensive effect is still not clear about the beta blockers. Name the beta blockers. Metoprolol, bisoprolol, atenolol, acebutolol, esmolol, good, propranolol, timolol, sotalol, nebuvolol, carvedal. Okay, so out of them, the common beta blockers which are useful in the management of the hypertension are atenolol, metoprolol, bisoprolol, carvedilol, nebuvolol. Okay. So as he said that cardioselective and non-cardioselective. So cardioselective is the beta 1, non-cardioselective is the beta 2. Lipid are the water soluble, lipid soluble. They crosses the blood-brain barrier, liver elimination, at least twice daily dosing. So the lipids are they crosses the blood-brain barrier. So that is the reason we use the propranolol for your tremors. Propranolol in the management of the glaucoma. Propranolol in the management of essential tremors or asthenia or aggressiveness, palpitations, etc. because they cross the blood-brain barrier. Water soluble, they do not cross the blood-brain barrier, once daily dosing and renal elimination. Intrinsic sympathomimetic activity, they partial agonist and the lipid neutral. These are the very, very common side effects of the beta blockers. And the most important one is the bradycardia. So whenever a patient is on beta blocker therapy, so in the follow-up, always check the pulse rate. So when the fellow is in the bradycardia, so definitely you have to reduce the dose of the beta blockers. Sometimes you have to stop it also. And once the fellow is in the tachycardia, even in spite of the beta blocker therapy, so there is always a role to increase the doses of your beta blocker. Okay, so the heart rate is a very, very important, paramount important in your follow-up to know the dose adjustments of your beta blocker therapy. Fatigue is very common with the beta blocker therapy. Insomnia, because it crosses the blood-brain barrier. The masked symptoms of the hypoglycemia. So that is the reason the people on the beta blocker therapy in a diabetic individuals, so hypoglycemia may not be recognized so often because the palpitations, aggressiveness, stressfulness, these are all will be masked by the beta blocker therapy. Again, they increase the triglycerides and decrease the HDL, so they are not lipid friendly. They decreases the exercise tolerance, increases the peripheral arterial insufficiency, so that is the reason they are very much contraindicated to the peripheral arterial diseases. So the peripheral arterial disease, the people with the claudication, intermittent claudication, or heavy chronic diabetics with autonomic dysfunction, etc. So better not to use the beta blocker therapy. CNS effects, depression, sedation, nightmares, these are very common with the beta blocker therapy and may exacerbate the heart failures. So these are all the side effects of the beta blockers. As a physician, you should know much more things about the side effects rather than the main effects of any drug. Okay, so these are all the common side effects. So every day you see the lot of the people using the atenolol or other beta blockers. So these are the common side effects. Okay, so bradycardia, fatigue, insomnia, they mask the symptoms of the hypoglycemia, dyslipidemia, reduces the exercise intolerance, and then contract in the peripheral arterial diseases, and CNS, depression, sedation, nightmares, etc. Bronchospasm. Non-selective beta blockers contracting in the reversible airway disease. So retinol, they cause bronchospasm. Even metoprolol may cause bronchospasm. So to avoid this bronchospasm, the beta blockers of use are either the bisoprolol or the nebuvolol. Beta 1 selective blockers, okay, provided the bronchospasm is under control. Heart blocks, bradycardia, already I told you, they decrease the left ventricular pumping. That is the reason sometimes they are contraindicated in the heart failure. But now, one of the main one of the four pillars in the management of heart failure is the beta blockers. But here, use the beta blockers of cardioselective, especially or carvedilol or bisoprolol. Very useful when introduced very cautiously in the chronic stable CHF. Special population, compelling indication. You should use beta blockers in these conditions. What are the ischemic heart disease? They reduces the mortality. So that is the reason the cardiac ICUs. So all the IHD population, myocardial infarction, post-PTCA, post-CABG, they will be given a small dose of the beta blockers, like metoprolol, maybe 12.5, or metoprolol 25 mg, or the bisoprolol 2.5 mg, etc. So in the treatment of the stable angina, they reduces the heart rate. So they are very good, useful drugs. The prevention of the sudden death. So a mortality benefit will be seen with the beta blockers. That is the reason beta blockers are the compelling indication to use in ischemic heart, either angina or post-MI or post-PTCA or post-CABG. Migraine headaches, we often use the beta blockers. Thyrotoxicosis, a very common indication. Here the tachycardia, the people will be restless, etc. So definitely a good indication to use it is a thyrotoxicosis. Here we use mostly the propranolol, maybe 40 mg BD or 40 mg TID or 80 mg BD. Cirrhosis with the esophageal varices, here we use the spironolactone. Then the calcium channel blockers, very, very useful drugs, excellent drugs. In fact, they are the most potent antihypertensive medications are the calcium channel blockers. So when I was an undergraduate or in the house agency, we used to give the depin sublingual in the casualty. So the nipidipine sublingual to reduce the blood pressure drastically. But now it is a big blunder using the sublingual nipidipine. Okay, we should not use the sublingual nipidipine no more, because it reduces the blood pressure very fast and causes lot of damage to the ischemic zone. So dihydropyridine, nifedipine, amlodipine, felodipine, non-dihydropyridine like the verapamil and the diltiazem. So these dihydropyridine calcium channel blockers, amlodipine and then the cilindipine is added recently. So these two are very, very important drugs to be used in the management of hypertension because they are the true 24 hours action. Whereas your nifedipine acts for about 6 to 8 hours, maximum 12 hours. So that is the reason nifedipine we give TID or the BD at least. So after the introduction of the amlodipine, so we are using a lot of the amlodipine rather than the nifedipine because of the good compliance once a day doses. Amlodipine is a very good drug in elderly individuals to reduce your ISH along with your diuretics. And amlodipine is a good drug to be used in all the cerebrovascular diseases. So the hypertension causing neurological side effects and definitely to reduce the blood pressure, amlodipine scores over the beta blockers. Beta blockers are very good as far as the heart is concerned. Amlodipine is very good as far as your brain is concerned. Okay. Non-dihydropyridine, here the diltiazem and the verapamil. So the diltiazem, we use it in unstable angina, pringimental angina, etc. And the verapamil, no more you are using the verapamil. But diltiazem, some cases in cardiology, in some cases of angina pectoris, we use the diltiazem. 30 mg available, 60 mg available, 90 mg available, and also sustained release of 90 mg and 60 mg is also available. Amlodipine dose, usual dose is 5 milligrams, and we have to start with the 2.5 milligrams, and then the 5 milligrams, 10 milligrams. In the CKD population, when the blood pressure is very high, even you can use the 20 mg of the amlodipine. They block the calcium channels, and thus the calcium entry in the vascular smooth muscle cells and cardiac myocytes and cardiac conduction tissue, so that they reduce the contraction or the conduction. That's how they help in reducing your blood pressure. Dihydropyridines, the predominant effect on the arterioles, they're the vasodilator, like your amlodipine and cilindipine or nifedipine. Non-dihydropyridines, like diltiazem and the verapamil, predominantly is the cardiac effects. They reduce the heart rate and the contractility. So that is the reason in pringimental angina or unstable angina, we use the diltiazem because they predominantly act on the cardiac tissue. Whereas as vasodilatory, so preferably a nifedipine or amlodipine or the cilindipine. This is the common side effect, is the headache, flushing, and most important is the peripheral edema. So the peripheral edema is a very common side effect of the amlodipine. So to reduce that, you can have another drug which can reduce the peripheral, not of high degrees of the peripheral edema like your amlodipine is the cilindipine. But cilindipine also will cause the peripheral edema. And the second class, non-dihydropyridine group, you will have the bradycardia and the heart blocks, constipation along with the verapamil, less likely the edema, headache or the flushing, because they are active mostly at the cardiac tissue, not on the arterioles, not as vasodilator. So as I told you, that is a drug of choice in the elderly individuals, angina pectoris, especially or diltiazem, and arrhythmias, control of the atrial fibrillation rate by non-dihydropyridine drugs like verapamil. Some controversy with the calcium channel blockers. Do calcium channel blockers increase the likelihood of the death from the myocardial infarction? So that is the reason we don't use the calcium channel blockers mostly in the myocardial infarction individuals. In the myocardial infarction setting, we use ACE inhibitors like your ramipril, maybe 2.5 mg or 1.25 mg, and we use the beta blockers like the metoprolol. Main concern was with the short-acting nifedipine, which causes the sudden vasodilatation and therefore compensatory tachycardia that can precipitate the myocardial ischemia. So in myocardial ischemia, we need to reduce the heart rate rather than increasing the heart rate. So the common side effect of the calcium channel blockers is headache, tachycardia, pedal edema, flushing, because they act as a vasodilatory agents. Newer long-acting agents like amlodipine, felodipine, and long-acting nifedipine have been shown to be safe in cardiac patients in several trials. Even then, we don't use these drugs as a cardiac protective drugs, because we have many drugs in our hand to use other than the amlodipine in acute myocardial infarction settings. Very useful drugs, ACE inhibitors. Especially the compelling indication to use ACE inhibitors is the type 1 diabetes, proteinuria, microalbuminuria. So this is a very, very important drug. They inhibit the enzyme ACE, thereby prevent the conversion of the angiotensin 1 to angiotensin 2. So you all know that angiotensinogen that will be converted to the angiotensin 1 with the help of the renin. And angiotensin 1 will be converted to the angiotensin 2 with the help of this ACE. Okay. Effect of the fall in the angiotensin 2 levels. So you will have the arterial vasodilatation, natriuretic effect, direct renal effect, lower the aldosterone levels, reduce the sympathetic nervous system activity, because they reduce the renin, they reduce the sympathetic activity also. They are the renoprotective, so they relax the efferent arteriole, so they reduce the intraglomerular pressure, so intraglomerular hypertension, intraglomerular hyperfiltration, so they all will be reduced with your ACE inhibitor therapy or ARB therapy, because they reduce intraglomerular hypertension. Direct antifibrotic effects, so cardiac friendly, renal friendly, via lower levels of transforming the growth factor beta. So that is the reason ACE inhibitors, they are not only the antihypertensive agents, but they are also cardioprotective, renoprotective, and vasculoprotective. So vessel is also very important organ in the body. So ACE or ARBs, they are not only the antihypertensive medications, they are renoprotective, cardioprotective, and vasculoprotective. Cough is very, very common side effect of. So the common here is the ramipril. What is the trial name given to the importance of the ramipril in all these medications? What the trial name? After the trial, the sales of the ramipril has gone like in a tsunami proposition. Starts with the letter H, 4 letters. HO, 4 letters. Last letter is E. Hope trial, excellent. So that is the best trial. Okay, conducted with ramipril. So the Hope trial showed that ramipril usage in all these diabetic individuals, and in those people, those hypertensive at high risk of hypertensive individuals, they reduces the cardiac events, they reduces the renal events, they reduces the proteinuria, they reduces having less and less vascular diseases. So that is the reason ramipril is a vasculoprotective, renoprotective, cardioprotective, along with your antihypertensive medications. Unfortunately, cough is very common with the ACE inhibitors, about 12% of the patients. Unfortunately, not of much cough in our Indian patients when compared to the Caucasians, Western population. Angioedema, swelling of the lips and the tongue. This is also very common with the ACE inhibitors therapy. Some people will have the angioneurotic edema after your ACE inhibitor therapy, even with the ARB therapy also. Okay. So hyperkalemia due to the low aldosterone levels. So we should not combine the spironolactone here, potassium sparing diuretics, with the ACE inhibitors ARBs, because they themselves cause the hyperkalemia. So these two common indicate, 3 you should remember in your lifetime. Cough is very common with the ACE inhibitors. If the person develops the cough with the ACE inhibitors, so what you do? When the fellow develops the cough with the ACE inhibitors, stop giving the ACE inhibitors and start giving the ARBs, because you have to protect the kidney, you have to protect the heart, you have to protect the vessels. So that is our paramount importance in treating the hypertension or hypertension plus diabetes. So those people who develop the cough with the ACE inhibitors, our answer is switch over to the ARBs. Okay, last one. Suppose the person develops the cough with one ARB. Name few ARBs. Tell me, Satan. losartan, candesartan, valsartan, olmesartan, okay, azilsartan, okay. So suppose the person develops cough with one sartan. So what is your answer? Which group? So next. This is a very common, no? Lot of the people are using these sartans nowadays. When they develop the cough, what to do? Wrong answer. When they develop the cough with the one sartan, change to the other sartan. When they develop the cough with the, see, when they develop the cough with the ACE inhibitors, stop all ACE inhibitors. Change to ARBs. In the ARBs, when they get the cough with the telmisartan, what the common drug you prescribe, telmisartan, then not change to the calcium channel blockers. Change the telmisartan to the olmesartan. When they develop the cough with the olmesartan, change to the valsartan or the candesartan or your losartan or your azilsartan. So that is the right answer. Okay. So angioneurotic edema is also very common with the sartans and the ACE inhibitors. See, these are the special populations. Definitely you have to use the ACE or ARBs in these situations. Heart failure. So out of the 4 pillars, the one pillar is ACE inhibitors or ARB or ARNI. ARNI is ARB plus neprilysin inhibitors. So valsartan plus sacubitril. So these three, either ACE or ARB or ARNI is the one pillar in the management of heart failure. So congestive heart failure inhibitors prolongs the life and reduces the symptom because they reduce the afterload. To reduce the preload in heart failure, you use diuretics. Renal disease, they slows the progression of the proteinuric renal disease. So they are renoprotective. In all the proteinuria population, we have to use either ACE or ARBs. Diabetes mellitus. Okay, they slow the progression of the diabetic renal disease at all stages, including the microalbumin. So even at the time of the diagnosis of the diabetes, you have to get the microalbuminuria. And once the fellow is on the microalbuminuria, once you have to start ACE inhibitors, even though the person is normotensive. That is very, very important take-home point. So don't expect that all the people will be hypertensive to start the ACE inhibitor therapy. Even though they are normotensive, when the fellow is having the proteinuria, so definitely there is a role to use ACE inhibitors because they are not very potent antihypertensive medications, unlike your amlodipine or other calcium channel blockers. Even you can use the 2.5 milligrams of the ramipril or 20 mg or 40 mg of the telmisartan, even at the blood pressure of 110 by 80 or 120 by 80. Even in the normotensives, you can start using the ACE inhibitors or ARBs to prolong the life of the individual, not to have the renal failure or the cardiac failure at a later time. So these are the sartans, angiotensin receptor blockers, ARBs. They direct antagonists to the angiotensin 2 at the receptor. So they directly act at the receptor level. The effects are similar to the ACE inhibitors, except they do not inhibit the bradykinin degradation. So that is the reason the chances of the cough will be less with the ARBs, where the chances of the cough will be more with the ACE inhibitors because they inhibit the bradykinin degradation. They do inhibit non-ACE production of the angiotensin 2. Losartan, valsartan, irbesartan, telmisartan, azilsartan, olmesartan. So different sartans are there. Now they are the number one drugs in the management of the hypertension. Most of the individuals, so they will be in separate combinations and one drug should be a sartan. So alpha blockers. Alpha blockers, we have the prazosin and the doxazosin. And out of them, prazosin is a very popular drug in the market. And common indication to use the prazosin is CKD, chronic kidney disease. Okay. In the chronic kidney disease, because when the creatinine level is 3.5 or 4, you should not use the ACE or AN base. Contraindicated to use when the creatinine level is more than 3 or the 4 or the 5, except in the hands of the nephrologist. Usually at the physician level, we stop using the ACE or AR base when the creatinine level is 3 or 3.5 or the 4. So on the other hand, hypertension is very, very common in CKD individuals, and accelerated hypertension, malignant hypertension, very high blood pressure is very common in the CKD population. So here, your prazosin, mini-press XL or prazopress XL, start with the 2.5 milligrams OD, BD, TAD, and slowly can go up to 5 milligrams BD or 10 milligrams BD or TAD. But one word of the caution in using the prazosin is first dose hypotension is very common. So first dose hypotension, postural hypotension is very common with the prazosin therapy. So that is the reason when you initiate the drug, you always tell to the patient, this is the last drug to be taken at the time, just before your bedtime. Okay. So after taking this prazosin tablet, if he stands for some time, so definitely there is a they may cause a postural hypotension and fall on the ground and may get a fracture hip or etc. So that is the very, very common advice one should give to this population, because we often use in the CKD population this prazosin. Direct acting vasodilators, hydrolysis, and another advantage of the prazosin is it reduces the BPH, benign prostatic hypertrophy. So that is the reason in elderly individuals, prazosin also had an added advantage once they have the BPH. Direct acting vasodilators, hydralazine, minoxidil. Nowadays, minoxidil being used by the cosmetic dermatologists. So there is a side effect, minoxidil. Side effect is hair growth. Okay. But actually they are vasodilators, antihypertensive medications. But we don't use much of the minoxidil because it reduces the blood pressure very rapidly, drastically. Hydralazine is good, is a potent vasodilator. So that is available in the market, hydralazine. So we often use the hydralazine as a fourth agent or the fifth agent in the management of the resistant hypertension. So in the resistant hypertension means we have to use the 3 or the 4 drugs, and one drug should be a diuretic. And even in spite of your sartan, in spite of your calcium channel blocker, in spite of your diuretics, in spite of your alpha blockers, still the blood pressure is very high. Then there is a role of adding hydralazine as a vasodilatory drug. Centrally acting agents like methyl dopa and clonidine. Methyl dopa is a very common used in pregnancy induced hypertension, alpha methyl dopa. But nowadays we are using labetalol. That's a combined alpha and beta blocker. That is the drug of choice right now. Clonidine, again we use it in the CKD setting. So these are newer agents: isilsartan, 1-sartan, cilnidipine, carvedilol, nebuvolol. These are the beta blockers. Last two are the beta blockers. This is the isilsartan is the more potent than most of the clinically available ARBs for inhibiting the binding of the angiotensin 2 to a human AT1 receptor membrane preparation. It has been available in the market for the last 3 to 4 years, but not that popular when compared to your telmisartan. They reduce the 24 hours BP in the hypertensive humans without the serious comorbidities more effectively than the maximum approved doses of the olmesartan, valsartan, or candesartan. Cilnidipine is very popular, not available in the UK, Europe, or in Australia or in America, but is very popular in Asia. Cilnidipine is a unique calcium channel 2 channel blocker. It has inhibitory action on the sympathetic nerve N-type calcium channels along with its effect on the L-type calcium 2 channels. You have the N and the L. Okay, amlodipine will act on the N-type of the channels, whereas cilnidipine will act both on the L and the N. This article focuses on the current status of the cilnidipine in the management of hypertension and comorbidities. Cilindipine, by increasing your norepinephrine release from the sympathetic nerve endings leading to the vasodilatation, decreases the heart rate and increases the renal blood flow. So they act on the heart, vessels, and also the kidney. In the heart, they reduce the cardiac contraction, reduces the heart rate. Unlike your amlodipine, which increases the heart rate, here the cilindipine will not increase the heart rate. That is the biggest advantage of the cilindipine. So that is heart friendly. Vessels, so basically it's a vasodilator, calcium channel blocker. So vasodilatation effect will be there. And also protects the kidneys. Increases the renal blood flow. So carvedilol is a beta blocker, often used in the heart failure patients. It's a non-selective beta blocker with alpha-1 receptor blocking activity and no intrinsic symptomatic activity. Clinical data suggests that carvedilol reduces the systemic vascular resistance in patients with the hypertension. Again, the Nebula is also very popular drug nowadays. Nebistar, 2.5 mg and 5 mg. Nebula is the beta-1 selective beta blocker that does not have the alpha-1 blocking activity or the intrinsic symptomatic activity. It reduces the systemic vascular resistance in patients with the hypertension, possibly through the stimulation of the nitric oxide release. So that is the advantage of the Nebula. So the Nebula increases the nitric oxide levels in the vessels. Nitric oxide is a potent vasodilator. So the more the nitric oxide, more the vasodilatation. It was generally safe and well tolerated. Had comparable efficacy with other beta blockers and antihypertensive agents. Now the combination therapy. So this is the present trend in the management of the hypertension. This is not the monotherapy, but a combination therapy. Only 5 to 10% of our hypertensive individuals in the society are on monotherapy. Because if you divide the hypertension into 3 grades, stage 1, stage 2, stage 3, and most of the people with stage 1, they may be controlled with a single drug. But 90% of our population are either the stage 2 or the stage 3. So stage 2 means the systolic blood pressure is more than 160 and the diastolic blood pressure is more than the 100. Stage 3 means systolic more than 180 and a diastolic more than 110. So 80 to 90% of hypertensives, their average blood pressure, systolic is more than 160 and the diastolic is more than 100. So where monotherapy is not sufficient, you have to go for the combination therapy. So this is the way. Why I consider combination therapy? Because the people present with very high blood pressure, it is very difficult to control the single drug. So you have to use the combination therapy. In combination therapy, you can attack the different pathophysiological mechanisms of the hypertension. So what is the pathophysiology of the hypertension? Not only your fluid overload, so there is a renin activity. So renin angiotensin aldosterone system. There is a sympathetic overactivity. So there is the heart rate. There is a peripheral vascular resistance. So these are all the different pathophysiological mechanisms causing the hypertension. So when you are using the calcium channel blocker, you are blocking the peripheral vascular resistance causing vasodilatation. And when you are using the sartans, you are blocking the renin angiotensin system. When you are adding the diuretic also to them, so you are controlling the fluid overload also. So in that way, the combination therapy is very beneficial in tackling the different pathophysiological mechanisms of hypertension. When to consider the initiation of the combination therapy? When the fellow presents with the stage 2 or the stage 3 of the hypertension. Which drug classes for the combination therapy? Mostly ARB plus CCB plus diuretic. Which individual drugs for the preference? Maybe sartans plus either amlodipine or cilindipine plus either hydrochlorothiazide or chlorothalidone. So always the consider for the single pill combination. So polypharmacy. When you are advising the 3 drugs, 3 individual drugs to swallow every morning, so the patient may not accept it. Suppose you are giving a single pill which contains all the 3 drugs, so definitely the compliance will be very good. So the compliance is very important factor. The most important neglected part in the management of any chronic diseases is the compliance. So blood pressure lowering is designed to be difficult is maintained by the multiple pressure systems, different mechanisms designed to resist the BP lowering. Redundancy inhibition of the one system activates the another. So structural changes, large and small arteries, maintains the peripheral resistance and systolic pressure, testing BP lowering. So that is the reason when you are using the drugs, these drugs should be synergetic. So don't use amlodipine plus cilindipine. Don't use ramipril plus telmisartan. Okay. So the drugs from the different classes can be useful as a synergetic activity. The counter regulation limits the monotherapy process. Vasodilatation or a diuretic, BP reduction, RAS activation, BP will be increased. So here which combination you prescribe? When you are using the amlodipine, you are good vasodilatation. When you are using the sartan, so they reduce the RAS activity. So obviously the second up will be also low. So the blood pressure will come down. Evolution of the hypertension in young, pre-hypertensive, then the hypertensive, then hypertensive plus damage, and then the clinical disease, and then the complications, etc. etc. So how to pick up the people at the pre-hypertension level itself, not to introduce the drug therapy, but to introduce the non-drug therapy, your lifestyle measures. We are all pre-hypertensives. Okay. So most of our people will get the hypertension in the near future. So this is the high time to develop to introduce the non-drug therapy or the lifestyle measures not to have the hypertension in the near future. Once you are an hypertensive, so definitely again you have to use the non-pharmacological measures to control the blood pressure, and also you need drug therapy. See, the vasoconstriction is very common in younger individuals. That is the reason we use the beta blockers. Sympathetic activity is very common in young individuals. So that is the reason beta blockers are the drugs of choice in young hypertensive individuals. Increased peripheral vascular resistance, vascular remodeling, RAS activity, SNS, sympathetic nervous system activity. So these are all very common in the younger individuals. In the older individuals, you will have the declining of the GFR because of the aging, maybe because of the multiple diseases. The CKD is a very common in elderly individuals. When you check the creatinine levels, it will be 1.8, 2.2, 3.2, asymptomatic individuals. Sodium retention is a very common there. Increased cardiac output, stiff aorta. So that is the reason isolated systolic hypertension. You have to use the number of the drugs. See the number of the drugs. 0 in the younger individuals, only with the non-pharmacological management. But as days goes on in older, so the newer drugs, multiple drugs, polypharmacy. So the plasma renin, ACE inhibitors, the ERBs, calcium channel blockers, etc. What are the guidelines? Your JNC8 or European Society of Hypertension, NICE guidelines, UK. See, all these most patients with hypertension will require 2 or more antihypertensive medications to achieve their BP goals. That is JNC. Combination treatment should be considered as a first choice when there is a high CV risk. So that is European Society. UK guidelines. Many patients will require more than the one drug to achieve the adequate BP control. So any international agencies or groups, they say that a combination drug therapy is very, very important in the management of the hypertension. No more a monotherapy in the management of the hypertension. The use of 2 or 3 drugs in combination is often necessary to achieve the target BP control. From tomorrow onwards, you follow one hypertensive patient. So every visit, every follow-up, you check the blood pressure. You will know the better. What are all the common drugs you are going to prescribe it? Is it the monotherapy or the combination therapy? So always the combination therapy is always useful. See, these are the different guidelines. Guidelines also recommend if goal BP is not reached within a month of the treatment, within 1 month of the treatment, the blood pressure is not under control. Maybe the blood pressure is still 140/90. Increase in the dose of the initial drug is the one option, or addition of a second drug from one of the other classes has been recommended. So usually we follow the second suggestion. Suppose today you have prescribed one drug, reviewed after 1 month. After 1 month, again the blood pressure is not at the target. Again the blood pressure is more than 140/90. Then you have the two options to increase your monotherapy drug from 20 mg or 40 mg of telmisartan to 80 mg, or 2.5 mg of your amlodipine or 5 mg to say 5 or the 10 mg. Or the second option is add second drug to that initial agent. So always adding a second agent to the initial drug is much more useful and more beneficial to the patient rather than the increment of your initial agent. If goal BP cannot be reached with the two drugs, again, a lot of the population are there, at least 40% of the people, even after the two drugs also, the blood pressure is more than your required number. Then the addition and titration of the third drug from the different class has been recommended. Okay, if goal BP cannot be reached with the three drugs, again, we have to add the fourth drug. If the goal BP is not reached with the four drugs, again, we have to add the fifth drug. So some of the individuals, they will be on the sartan, calcium channel blocker, diuretic, alpha blocker, central acting drugs like the arcamine, etc. Or a potent vasodilator like hydralazine. So this is a set of different people will be there in the society with a mild hypertension, moderate hypertension, severe hypertension, very, very severe hypertension. With they need lot of the medications, etc. Ultimately, don't count the number of the medications you are giving it, but always pay attention to the blood pressure of that particular person. So if the blood pressure is reached to the 120/80, even with the 5 drugs or the 6 drugs, I'm happy. Okay. Consider the BP level before the treatment, absence or the presence of the target organ damage in the risk. This is a very important take-home point. So whenever you see a patient with hypertension, you always look for the target organ damage in them. So what you mean by the target organ damage? Maybe retinopathy, maybe proteinuria, maybe LVH, or TIA, or keratoderma media thickness, or ankle brachial index, etc. So this is the very, very important about the target organ damage, and act accordingly. Marked BP elevation, higher. So mild BP elevation, low dose or single agent, full dose single agent, not at the BP goal, not at the BP goal. So definitely we have to initiate the multiple drugs. Very, very popular combination in Indian pharmaceutical industry. So most of the drugs will have the trio. Trio means your Telma trio, etc. So you will have the ARB, telmisartan, plus amlodipine, plus chlorthalidone or hydrochlorothiazide. See, when the fellow is less than the 55 years of the age group, you can start with the ACE or ARB. When the fellow is more than the 55 years, you can start with the calcium channel blocker or thiazide type diuretics. In step 2, combine these two drugs, ACE or ARB plus CCB, or ACE or ARB plus thiazide type diuretics. In the step 3, all the 3 drugs, ACE or ARB plus CCB plus thiazide type diuretics. And the step 4 is very important. Add further diuretic therapy or alpha blocker or beta blocker. Consider seeking the specialist advice here. See the beta blocker therapy in the stage 4. Okay. So earlier beta blocker were the first initial drugs to be added. But now after ARB, after CCB, and after the diuretics, you will have the beta blocker therapy. But there is a compelling indication to use the beta blockers even as the initial agents of the choice, provided if the patient is having ischemic heart disease, provided if the patient is having heart failure or tachyarrhythmias. So definitely have to use the beta blockers as a compelling indication to be used. Fixed dose combination, antihypertensive is the answer. Okay. So synergetic effects, they reduce the adverse events, they improve the compliance because the single drug, fixed dose combinations. Synergetic effects, higher antihypertensive efficacy than the individual components because you are using the combination, so enhanced activity. Blood pressure lowering efficacy of combining 2 different classes is approximately 5 times greater than the doubling the dose of the one of the components. See the advantage here. Blood pressure lowering efficacy of combining two different classes like amlodipine plus your metoprolol or your sartan plus amlodipine is approximately 5 times greater than the doubling the dose of one of the components. So that is the reason combination therapy is preferable than the monotherapy. Higher reductions in the risk of developing the CAD and the strokes when you are using the combination therapy. Reduced adverse events, reduction in the adverse events frequent observed with the specific combination strategies. Adverse events are less than the 82. Sometimes no synergetic effect. Suppose you are using the calcium channel plus beta blocker. Calcium channel blockers will cause tachycardia and beta blockers will cause bradycardia. So the pulse rate will be the normal. Improved compliance, so lower rate of discontinuation compared with the initiating the treatment with the monotherapy may allow the dose titration treatment without increasing the pill burden. So this is the advantage of the fixed drug combinations. So the RAS blockades with the sartans, calcium channel blocker and the diuretics. BP lowering drug efficacy monotherapy. See the monotherapy here. The systolic. Thiazides standard dose fall in the BP. Twice standard dose 8.8, 8.8, etc. Thiazide diuretics, beta blockers. On average 9.1 systolic BP reduction. Whereas the diastolic BP on average it is about 5.5 with the monotherapy. See the combination therapy. The both drugs together, the systolic fall will be up to 14 and the diastolic fall will be up to 8. So the more fall in blood pressure will be seen with the combination therapy rather than the monotherapy. See the diuretic or the CCB, natriuretic and vasodilatation RAS activation. So there will be the good fall in the blood pressure because of these triple activities. Calcium channel blockers, they decrease the glomerular afferent arterial pressure. So they stimulate the RAS activity. Diuretics, the loss of the sodium will stimulate the RAS activity. So opposite effects on the RAS offers the stronger antihypertensive efficacy when used in the combination. ARBs have the best treatment adherence of all the hypertensive classes. Amlodipine is the most CV protective calcium channel blocker in the landmark studies because amlodipine is available all over the world, whereas the cilindipine is available only in Asian countries. So when you see the literature, so the more and more papers are on the amlodipine, like your PREVENT study or Camelot or ASCOT, LHAT. Complementary effects of a calcium channel blocker and RAS blockade, reduction of the CCB associated edema. See, you concentrate on this slide. See the arterial hypertension, constricted the blood vessels. See the afferent arterial and the efferent arterial. High resistance. So when you are using the calcium channel blockers, BP reduction due to the arterial vasodilatation, tendency towards the edema due to the absent venodilatation. BP reduction stimulates the RAS and increases the angiotensin II level. If you see the third picture, you are using the calcium channel blockers plus RAS inhibitors. See, the blockade of the RAS inhibits the effects of the angiotensin II, giving rise to the additional BP reduction. Additional venodilatation by the RAS inhibitors reduces the edema. Okay. See the first picture, the vessels are very constrictive, both afferent and the efferent. When you are using the CCBs alone, so you have a good effect on the arterioles, but not on the venules. When you are using the CCB and the RAS inhibitors, both arterioles and the venules, so there will be the good dilatation and arterial dilatation and reduces the intraglomerular pressure and you will have the more beneficial effects here. So these are the advantages of the combination of the calcium channel blockers and RAS inhibitors. So the benefits, the BP goal may be achieved more rapidly than with the monotherapy. Greater reductions in the BP and higher BP response and control rates versus the monotherapy. Reduces the adverse effects due to the lower doses of the individual agents. Lower doses effective due to the complementary mode of the action. Fixed dose, single pill combination, they reduce the pill burden, improves the compliance, treatment adherence, may cost less than the individual components prescribed. Most hypertensive patients will require 2 or more agents to achieve the target blood pressure. Combinations are there. They have the complementary mechanisms of action. Limitations, loss of flexibility with the single pill combinations. So single pill combinations improves the treatment compliance, chronic diseases, hypertension, etc. So why? For the combination therapy. Hypertension is one of the most common preventable causes of the death. Yet it remains an increasing the health problem. You don't require any high-tech investigations like CT or MRI, etc. With your BP apparatus, you can define the blood pressure, but still it is the #1 killer in the world. So we have to upgrade our knowledge on the hypertension, and you have to think yourself once or twice to initiate the good management for all our hypertensive individuals, identify the hypertensives much early, and give the non-drug therapy advice, and also the drugs according to their weight, according to their age, according to their compelling indications. That is how we can reduce the morbidity and the mortality. Many patients in India require at least 2 antihypertensive medications. Combining the 2 drugs may not be enough. Thus, 15 to 22% of the patients would require combination therapy with 3 agents to control the blood pressure effectively. Fixed combinations allow the simplicity of the dosing and improves the adherence. The risk of non-compliance to medication regimen is reduced by 25% with the fixed dose combinations. Follow-up, monitor the renal function and serum potassium levels whenever you are using the potassium sparing diuretics or ACE or ARBs. Always reinforce the lifestyle modification every visit. Every visit of your hypertensive patient, you please concentrate on the non-drug therapy and then give good drugs therapy also. Reassess the adherence. Weight management is very, very important. Alcohol abstinence is very important. Life stress. So de-stress measures are very important, especially the meditation is very useful to reduce our stress and coexisting medical problems. Elderly people, BP should be lowered gradually, not suddenly, because they cause postural hypotension and falls and fractures. Titrate the initial drug and substitute the another agent. Patients not control the 3 drugs. So definitely we have to rule out the secondary hypertension, any cause for the secondary hypertension. So in conclusions, controlling the hypertension reduces the CV outcomes. Doubling of the CV risk with the BP increases of 20/10. Whenever the systolic more than the 20, diastolic more than the 10 of your target, so the risk will be doubled. Relationship between the BP and the CV risk is continuous. Always lower is the better. So 130 systolic and 135 systolic. 135 is dangerous. 135 systolic and 145 systolic. 145 is dangerous. So any BP more than your 120 systolic, any BP more than your 80 diastolic is always harm to the body. Majority of the patients require more than 2, 3 or 4 to achieve your BP goal. Multiple combinations have been well studied. Patient response to the fixed dose combination is predictable. Incremental efficacy with good tolerability achieved with the combinations representative of several antihypertensive medications, not just the thiazide combinations. Benefit risk profile, this is very, very important. Whenever you give a polypharmacy to a hypertensive patient, you should know the risk versus the gain. When the gain is more, you updated the dosages. So thank you very much for your patient hearing.